Welcome to Board Pearls. This is episode 6 of 6 of the GI and Pregnancy chapter in the Special Populations and Acute or Supportive Care module. In this episode, we cover the last two luminal problems of pregnancy: post-bariatric pregnancy with internal hernia as the catastrophic post-RYGB complication, and cholelithiasis with the procedural decisions, including ERCP using second trimester preference and lead shielding and pulsed fluoroscopy. The last episode governed IBD by disease activity. These two run on anatomy and timing. Start with post-bariatric pregnancy, where the organizing logic is anatomical. Every clinical rule in this section follows directly from what the surgery changed. Conception is delayed 12 to 24 months after bariatric surgery, and the reason is two-sided. The rapid weight loss phase is the wrong nutritional environment for fetal growth, because caloric restriction during organogenesis raises low birth weight and growth restriction risk. And the surgical anatomy is still adapting, and the patient's micronutrient stores are still being repleted during that window, so conception too early lands in a compromised maternal state. Roux-en-Y gastric bypass changes absorption in a predictable pattern, and the pattern reads off the anatomy. The duodenum and proximal jejunum are bypassed for ingested food. That is where iron absorption peaks and where calcium absorption peaks, so iron and calcium go down. The gastric pouch is small and largely bypassed for parietal cell exposure, which means intrinsic factor secretion is reduced and B12 absorption is impaired. Folate, vitamin D, and the fat-soluble vitamins A, D, E, and K also drop because the absorptive surface for fat-soluble nutrients shrinks. Thiamine becomes deficient whenever vomiting is sustained. Sleeve gastrectomy produces less malabsorption than bypass, but still impairs B12 because the parietal cell mass is reduced, and still threatens thiamine when vomiting occurs. The practical consequence is that micronutrient supplementation is mandatory through pregnancy in both procedures. B12, iron, folate, calcium, vitamin D, and thiamine are all followed and adjusted as needed. Gestational diabetes screening is one of those decisions that follows directly from altered anatomy. The standard 75-gram or 100-gram oral glucose tolerance test is avoided in post-Roux-en-Y patients, and the reason is the bypassed pylorus. The pylorus normally meters carbohydrate delivery into the small bowel. After Roux-en-Y, ingested glucose dumps directly into the jejunum. Early dumping comes from the osmotic fluid shift and produces nausea, palpitations, and hypotension within the first 30 minutes. Late dumping comes from reactive hyperinsulinemia and produces hypoglycemia at 1 to 3 hours. Either response makes the OGTT both uncomfortable and uninterpretable because the glucose curve no longer reflects underlying insulin handling. Fasting glucose paired with home glucose monitoring replaces the OGTT in these patients. Now the post-bariatric emergency that the boards return to, which is internal hernia. The mechanism follows from the surgery again. Roux-en-Y creates several potential mesenteric defects. Peterson's space sits behind the Roux limb. The jejunal-jejunostomy mesentery has a defect. If the Roux limb is brought up through the transverse mesocolon, that defect exists too. In late pregnancy, the gravid uterus displaces small bowel upward and changes the intra-abdominal pressure relationships, and bowel can herniate through one of those mesenteric defects. The presentation is severe acute abdominal pain in a post-bypass patient in the second or third trimester, often localizing to the right upper quadrant. This is the place where careful reasoning leads to the wrong answer if you are not anchored. A pregnant patient in the second or third trimester with severe right upper quadrant pain and vomiting looks like labor, looks like hyperemesis, looks like biliary disease. In a post-Roux-en-Y patient, it is internal hernia until you have ruled it out. Misclassification as labor or hyperemesis allows incarcerated bowel necrosis to develop within hours, and the maternal and fetal mortality, if missed, is high. CT with abdominal shielding is appropriate even though it carries fetal dose, because the alternative is missing a surgical emergency. Surgical exploration is prompt when the suspicion is real. The board pattern is severe abdominal pain in late pregnancy after gastric bypass equals internal hernia evaluation, not labor evaluation. Marginal ulcers at the gastrojejunal anastomosis are the other post-RYGB problem to know. The mechanism is exposure of jejunal mucosa to acid that the jejunum is not adapted to handle, and the risk factors are smoking, NSAIDs, and H. pylori. NSAIDs are avoided after Roux-en-Y for that reason. Treatment of a marginal ulcer is PPI plus reversal of whichever risk factor is present, and H. pylori is eradicated if positive. Breastfeeding mothers continue micronutrient supplementation through lactation because the same malabsorption pattern still applies, and infant B12, vitamin D, and calcium are monitored downstream. So the way to hold post-bariatric pregnancy is this. Every rule reads off the anatomy. Bypass duodenum and proximal jejunum drops iron and calcium. Reduced parietal cell exposure drops B12. Bypass pylorus invalidates the OGTT. Mesenteric defects plus a gravid uterus equals internal hernia, and right upper quadrant pain in a post-Roux-en-Y patient in late pregnancy is internal hernia until proven otherwise. The last section is cholelithiasis and the procedural decisions that come with it, and here the organizing logic is the trimester window. Gallstones develop in about 10% of pregnancies through the same lithogenic mechanism covered in the first episode. Estrogen-driven cholesterol secretion into bile, decreased bile salt secretion, and progesterone-impaired gallbladder contractility. Symptomatic biliary colic affects about 1 in 1,000 pregnancies, and pancreatitis or cholecystitis about 1 in 10,000. A first episode of mild biliary colic is managed conservatively with diet modification and pain control. Most stones do not progress through the pregnancy, and surgical risk is meaningful enough that deferral makes sense when symptoms are mild. Recurrent biliary colic, complicated cholelithiasis, or gallstone pancreatitis crosses the threshold into operative management, and the operation is laparoscopic cholecystectomy in the second trimester. The reason the second trimester is the right window has 3 pieces. Organogenesis is complete, so anesthetic and surgical exposure no longer carry the teratogenic concern that drives first trimester deferral. The gravid uterus has not yet grown enough to crowd the operative field, which becomes a real problem by the third trimester. And miscarriage risk associated with anesthesia and surgical stress is lower than in the first trimester. Second trimester cholecystectomy threads all 3 windows. ERCP in pregnancy is reserved for cholangitis, persistent biliary obstruction, or a large stone with refractory symptoms. The procedural framework is built around radiation minimization because ERCP is the one biliary intervention that brings ionizing radiation to the fetus. The teratogenic dose threshold is 50 mg cumulatively, with greatest sensitivity in the first trimester during organogenesis. The fetal dose target for ERCP in pregnancy is under 1 mg, which sits well below that threshold. Getting under 1 mg requires a stack of techniques that work together. Limited fluoroscopy is the first principle. Live fluoroscopy time is minimized, and brief intermittent imaging replaces continuous imaging. Post-fluoroscopy at a low frame rate dramatically reduces dose per unit of imaging time. Lid shielding is placed around the maternal abdomen and pelvis to attenuate scatter. The endoscopist works to acquire biliary access with as little image time as possible. Where feasible, non-fluoroscopic wire-guided cannulation replaces live imaging with tactile and endoscopic feedback. That lowers radiation dose further. Propofol is preferred for sedation because of the pregnancy safety logic covered in the broader sedation framework in Chapter 28. Pre-procedural imaging deserves its own note. MRCP without gadolinium is the preferred imaging when biliary anatomy needs to be defined before the procedure. MRCP carries no ionizing radiation, no contrast risk to the fetus when gadolinium is omitted, and gives the operator enough anatomic information to plan a focused ERCP with minimal exploratory fluoroscopy. Antibiotic selection for cholangitis or gallstone pancreatitis in pregnancy follows known fetal toxicity mechanisms. Fluoroquinolones are avoided because of cartilage signal in animal studies. Tetracyclines are avoided because they bind to fetal teeth and bone, producing yellow-brown staining and impaired enamel formation in the developing dentition. Beta-lactam plus beta-lactamase inhibitor combinations such as ampicillin-sulbactam or piperacillin-tazobactam are appropriate. Cephalosporin plus metronidazole is the other standard option. The principle is that the beta-lactam class has a clean pregnancy safety record, and metronidazole is acceptable in pregnancy outside the first trimester for the indications where its anaerobic coverage is needed. Sludge typically resolves in the postpartum months as the lithogenic hormonal environment unwinds. Stones identified during pregnancy persist in about 80% of patients afterward. That means an interval cholecystectomy is often appropriate postpartum for patients managed conservatively through the pregnancy. So the way to hold biliary disease in pregnancy is this. Trimester drives every decision. Mild and uncomplicated stays conservative. Complicated goes to laparoscopic cholecystectomy in the second trimester, because all three windows align there. ERCP is reserved for cholangitis or persistent obstruction, and is built around getting fetal dose under 1 mg with lead shielding, pulse fluoroscopy, limited live imaging time, non-fluoroscopic cannulation when feasible, and propofol sedation. Antibiotic choices read off mechanism. Avoid the agents with known fetal tissue targets. Use the beta-lactams and the cephalosporin-metronidazole combinations that have a clean record. Pull the two sections together. Post-bariatric pregnancy is governed by anatomy. Every nutritional rule, every screening modification, and the late pregnancy emergency of internal hernia read off what the bypass changed. So right upper quadrant pain in a post-Roux-en-Y patient in late pregnancy is internal hernia until proven otherwise. Cholelithiasis is governed by the trimester window. Conservative when mild, second trimester laparoscopic cholecystectomy when complicated, and ERCP only when the indication is solid and built around a radiation minimization stack that keeps fetal dose under 1 mg. That brings us to the end of GI in pregnancy. The next chapter turns to hereditary GI cancer syndromes. The diagnostic framework opens with universal MSI testing on every colorectal cancer. It runs through Lynch syndrome and its MMR gene-specific cancer risks, FAP and the broader polyposis spectrum, Peutz-Jeghers, and Cowden. It covers hereditary diffuse gastric cancer with CDH1 and the role of prophylactic gastrectomy, hereditary pancreatic cancer, and the CAP surveillance protocol, and the multi-organ coordination that cascade testing requires. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 6 of 6 of chapter 35, and I'll see you in the next one.